Okay, so we're all here today for the ESAS Professional Readiness Attitudes and Values session, and be presented by Stephen G. Stein. This presentation is a part of the ATTC network, which is a national US-based network. This map on the screen shows the locations around the country and where you can find them. And the content of this event is the creation of the presenters. The opinions expressed do not necessarily reflect the views or policies of SAMHSA, HHS, or the American Indian and Alaska Native ATTC. And following today's event, you're going to receive a follow-up email from us, which is going to include a link to these slides and the recording, information on how to request CEUs, and there'll be a link to the evaluation survey, our GIMPA survey, and we really appreciate if you fill that out. It tells us what we can improve and change for next time. This will also be linked in the Zoom chat towards the end of the meeting for you to fill out as well. And we also like to take some time during our presentations to do a land acknowledgement. So we give everyone a minute or two to read this. This is created by members of our team, Ella and Keely Driscoll from the Winnebago and Meskwaki Nations, and Sean A. Bear. Thank you. And today's speaker is Steve. Earned his BA in Communications in 1994 and his MA in Substance Abuse Counseling Program from the University of Iowa. Certified alcohol and drug clinician with the state of Iowa since 1997. He was born and raised in Iowa and has worked in the behavioral health services and nonprofit sector for 23 years, providing both direct patient care and as a clinician, provided supervision as a clinical manager. Since January of 2019, he's been working for the National American Indian and Alaska Native ATTC at the University of Iowa. He's been in recovery for over 35 years and has committed his life and profession to helping others in the recovery process. You can see him probably at the top left of your screen. I'll turn this over to him now.
Oh, Parker, thank you for that introduction. I really appreciate it. And good afternoon or good morning, depending on where this broadcast finds you. I know we've got a few attending that I think are from the Alaska territories. So glad to have you all here, and good to see a few familiar faces. And if you can flick your camera on, we'd love to see your face too. So yeah, I just want to welcome everyone. Want to I really hope that this webinar today finds you in a good place, and just want to forward and extend my appreciation for you all being here, and wish you all the best. I want to take a moment too to acknowledge a colleague and a friend of mine, Doug Widow. I asked him to drop in today and help me address some of the cultural considerations that we're going to touch on today in today's webinar related to professional readiness and values. So I'm going to try and get my slide deck up here so we can move through this. It's not a huge slide deck, so we may stop a couple of times, but throughout the webinar today, please utilize that chat box, or feel free to unmute and make a comment if you have questions or comments. Really would love to hear from you. This content that we're going to go over today, for some of you, it may be kind of a refresher. I know historically we've had people attend these that are working in the field, have been credentialed for a while, and we have others that maybe are newer to the field or looking to become credentialed. You're all welcome to attend for any of those reasons. Those of you that are new to the field, some of this might be things that you have read about or have talked to your peers about, and others that have been in the field a while are going to recognize some of these concepts and ideas. So just wanted to put that out there. Again, great to have everyone here. Dr. Garcia was scheduled to present this today, and she had some things come up, and I agreed to cover for her. So she wanted to tell everyone hello and that she'll be back doing this. I think she's scheduled to present later on this year. Next month, we're going to talk about HIV, STIs, and substance use disorders. And we have a guest lecturer named Dr. Matt Ignacio that will be joining us for that webinar next month. So watch for that one. Hope to see you tune in. Let me see if I can get my slide deck up without breaking anything. And I should be able to pull this off. I've got Parker there in the wings just in case I blow this. So let's see if I can get this into a good frame here. Parker, how's that looking? We have full screen there. Oh, I see. Yes, I see Melanie shaking her head. That's great. Maybe Parker has stepped off. Maybe he has, yes. So I appreciate that feedback, Melanie. You guys should be seeing the full screen without the notes section. So if we're on that page, which it sounds like we are, we're in good shape. So again, I'm coming from a clinical background myself. I've been here at the center working with colleagues like Doug for the last 4.5 years. I can't believe it's been quite that long, but a lot of my experiences are in a clinical setting in a kind of a Western, more standardized Western approach. So that's really where I'm drawing from. But over the course of the last 4.5 years, I've learned quite a bit about traditional healing and other pathways to recovery as they relate to substance use disorders. So it's been really enriching and enlightening for myself to see things from a little different perspective, not so linear, maybe looking at it more globally and from a different lens. So consultants, colleagues like Doug have been a big part of helping to teach me and help me understand a little bit better. So I always appreciate continuing to learn, professionally as I move forward. So let's talk about professional readiness and what that entails, and we're gonna touch on several key things, and there they are. We're going to touch on. Hopefully, we should have plenty of time to touch on each one of these topics, and I've added a couple of things, since the last time we did this. So you might see a couple of things different if you sat through this broadcast before. But hopefully we'll have a chance to touch on each one of these areas as they relate to this notion of professional readiness, values, and attitudes. So I think probably the first area that we can touch on would be just the clarification of values. So asking yourself, what are the standards that you follow? What guides you in your practice? We know that there are ethical guidelines. We know that there are best practice guidelines. There are a number of agency-driven policies and procedures that sometimes will shape and enhance how we do our work and how those interface with our own values professionally and personally sometimes can be, really impactful. So we would ask ourselves, things like where are my knowledge and skill sets best used? Are you getting the support you need, from your supervisor or from your peers or from your agency? And do my individual values conflict with the organization's values or expectations? An example I might give would be, and I'm not really necessarily saying this because I disagreed with it, but the clinic that I worked at for many years, they had a clear policy. This was a behavioral health clinic that we served a number of patient groups with substance use disorder issues. But we had a policy at that agency that you were not to disclose your recovery status to the patients. And it conflicted with, in many ways, with, as a person of long-term recovery, that conflicted with my values and the value that I placed on the importance of being able to self-disclose at certain times with patients when it was appropriate. Um, so that's just something, I wanted to share. And, my area of expertise and training ideally should match with the services and the patient population I'm working with. If not, I need to really take a look at that, and look at my training needs and my scope of practice as a professional. Um, I would say this a lot to my staff when I was managing the outpatient department. You are only as effective as a clinician as the support that you get and the people around you. So even if you're in private practice, having proper support is essential. Regular supervision and oversight support can make the difference in the work you do in those patients that you serve. There's other things to consider as well, and we'll touch on these. There's an ethical component as well. This is fundamental to the work that you do as a professional, and to really operate at your fullest potential. If there is a clear and convincing evidence that your agency's policies and procedures are incongruent with your own, then you need to again ask yourself, why did I decide to work at this agency? And I would add that most of us will not successfully interview and or accept a position with an agency whose mission or philosophies don't align with ours. So, I got into the work that I did because it was a nonprofit, and overall, the overarching mission statement of that agency that I worked for many years was very, very good, and assisting those that might not otherwise be assisted, and connecting with patients that might otherwise slip through the cracks. So that's what kept me, at that agency for many, many years. So again, looking at the clarification of values, the standards may be set by the organization in which we work. And we're asking ourselves, what is the overall agency's mission and goals? Whose needs are being met? Our needs, or the agency's needs, or the patients? As soon as we start putting paperwork and profit ahead of patient care, then that's a conflict. That can be an ethical dilemma for many, and it can be a professional and clinical concern as well. And again, I would encourage you guys, as you're listening, to chime in the chat box and let me know, and if we want to stop and process some of that. But again, asking yourself, how can we improve upon the services that we are offering? So best practice, staying current with best practice, or the blending of some approaches. If you're working in a tribal agency, the blending of traditional healing approaches with Western approaches, that may be absolutely vital to meeting the needs of the patients or relatives that you're working with. Again, your fundamental values should match, with the agency that you work with. This is really about you having the right platform or venue to help your patients heal and grow and find meaning in their therapeutic experience with you. Again, let's talk a little bit more about values. I mentioned this earlier, but there are a number of ethical codes that we follow depending on our area, our discipline. A code of ethics should naturally align with your own ethical principles. There are some core elements to many of the ethical guidelines within the helping professions that derive right from best practice principles, and what we know has worked and is working for many of our patients. So again, looking at those standards set forth by our profession. I'm kind of glancing at the chat box too, in case if I don't see your chat come in, feel free to unmute and jump in there. So I know many of you are practicing and have a lot of your own lived experience and clinical experience to share on. Again, looking at values, commitment to the patient, self-determination, and cultural competence and social diversity. These are all elements that we should consider. One of the things, the overarching things that I used to share with the clinicians that I was training or mentoring is the more we involve our relatives in their therapy and decisions about the direction that they want to move, the more meaning and purpose they will attach to their experience. And I know this is something that's been said by others, but a patient will often not remember what you said content-wise. They may be more apt to remember the way you reacted or didn't react, but what they're really going to remember, and I've experienced this, is they're going to remember the way they felt when they were with you. That will stay with them long after, any relapse prevention techniques or brain neurology or drug facts. They're not going to remember a lot of that specifically, but they're going to remember how they felt when they were with you. Did they feel unconditional positive regard? Did they feel listened to and advocated for? Those kind of feelings will stay with them throughout their recovery. Whether they're successful or not in their recovery, they're going to remember how they felt when they were with you. I hope that makes sense. I don't know if anyone else has a comment on that or has experienced that either as a patient or as a caregiver. It's a powerful concept. Let's look at culture. The word culture describes an integrated pattern of human behaviors that include thoughts, communications, actions, etc. That's what makes up one's culture. There are the National Association of Social Workers has standards for cultural competency in social work practice. So there are many of the disciplines that we find ourselves working in within the helping professions have specific cultural competency and awareness requirements for staff, especially if you're working with a very diverse population group. But even if you work with a more homogeneous group that is similar in many ways, there are still components to being culturally competent. Let's keep going. Anyone have any thoughts about that? Cultural competency, is that a term that some of you are familiar with? I suspect so, but certainly you can jump right in there and let me know if you want to comment on any of these slides. I'd love to hear from you. Let's look again at cultural considerations. There are some American Indian, Alaska Native cultural risk factors to consider. One is privacy, confidentiality, and what that really promotes is this notion of trust, and this can sometimes be concerning if you have a patient who has had issues with that in the past, where their information was disclosed or was shared with someone without their consent. Other things to consider when we talk about American Indian, Alaska Native specific cultural risk factors or considerations is sometimes the lack of social services, particularly in rural areas or on reservation. Again, this is linked to that, but limited access to comprehensive health care, and to also keep in mind components around circular migration. So you may have a patient who is traveling for work, and that work may take them out of the region and bring them back. So that may impact how engaged they appear, in their treatment, or how likely it is that they can stay engaged or continue to attend. And of course, unresolved trauma, grief, and loss. Whether this is historical or current, whether it's direct or indirect. So these are all, there's some examples there, but these are all things to consider as well. And then also just other experiences with racism or discrimination due to sexuality or sexual identity issues. So those are all cultural considerations that in talking with my colleagues, my Native colleagues here in our consultant group, as well as our advisory group, that have been noted. And I see Doug has stepped away, so I was going to see if he maybe wanted to comment, but maybe we'll come back to that. So I want to ask the group, I want to stop for a moment and ask the group, when you hear that term cultural competency, what is the first word or two that comes into your mind? If you want to put something in the chat or unmute and maybe shout something out. You can shout at me. I won't take it personally, I promise. But what comes to mind? Those of you that are listeners today in our smaller group here, what comes to mind when you think of cultural competency? Let's see. Doug, I was asking the group what comes to mind when they think about the term cultural competency. And just seeing if we can get some chat responses here. If give me kind of an idea. Oh yeah, here we got some coming in. Yes, good. That's good, Cheryl. Yep. Yes, I like that, Jeff. Hey, Jeff, I didn't see you there. Jeff is in our consultant group as well. Good to see you on, Jeff. Hope things are well up there in Alaska. Yeah, Greg, I agree. I like that term, compassionate ally. Awareness, yes. Yes, that makes a lot of sense. Ayana, that's right on. Having a level of awareness. Yeah, humility. Thank you, Alexandria. That's good. Yeah, Miriam, variety of cultures, good. Melanie, yep. I like that. Understand the people you work with. That could be colleagues or patients, right? I mean, it's in both those it applies. Yes, Louise, language. Yep, good. That's great. So yeah, let's move forward on this notion of cultural competency. Doug, what do you think of when you think of the term cultural competency? What comes to mind for you?
Well, first off, it goes back to for me, the left brain and the right brain. Almost. I was talking to my coworkers. As soon as we walk out that door of this office, we have to switch our thinking, and then as we come in, we have to switch it too. And so, but if you can't learn the language or make sense of things culturally if you're using your left brain. Then it becomes complicated, and then, but if you use your right side of your brain, then when you're going into culture, then you don't have to make sense of it. But if you're using your left side, it complicates things. And so it's really good to, the way I describe it, it's like that teepee, that top of that teepee's got that twist. And so we have to make that twist by either coming to work or heading into ceremony or just thinking in that way. Here we push for the culture. So when you come in here, we try to flip it to the right side. Thank you.
Yeah, thank you, Doug. Yeah, Doug and I were thinking if I could install a switch on the side of my head to flick off that left side of my brain, I might have a chance, Doug. I just can't find anybody to install that switch, so I don't know if you can connect me with the right person, Doug. We can work that out. Let's look at cultural humility, and and this can be something that it comes naturally to some, and to others it can be a real barrier. But other ways to sort of look at this, think of this cultural humility, this concept, as sort of a lifelong endeavor to take a look at your own understanding of things, how it relates to others who may see things through a different lens. But it's an ongoing process. That's one way to look at this idea of cultural humility. And let's take that back to the beginning of our conversation about your readiness and your preparedness as a professional to work with a wide range of individuals, either from a cultural standpoint or a value standpoint. You may have, Doug and I talk a lot about, an indigenous person maybe being more traditional, or maybe they're not connected to their culture at all, or they're somewhere in between where they're bicultural. This can manifest itself in many ways with patients we work with who are non-native as well. Another way to think about cultural humility is to really looking at the power imbalances in this. It should be not physician-patient, but in the clinician-patient dynamic. So readdressing, that sort of, I'm the expert and you're here, and being able to even the field a little bit and really working collaboratively rather than in this power imbalance. And then to develop mutually beneficial and non-paternalistic partnerships with communities on behalf of people you're working with. And this can be tricky too when it comes to confidentiality, but the idea is that you keep this open perspective, that you can be both the teacher but also be the student and continue to learn and grow and expand your understanding of maybe someone who sees the world differently than you. Some key sort of distinctions or things to keep in mind as we look at this idea of cultural competency. And remember, we're relating this to your own professional readiness. So kind of put it through that filter as we review these slides together. This idea, again, of cultural competency, it acknowledges that we can never become truly competent in someone else's culture. And, and I think that's something that has an element or a component of humility to it, staying right-sized, as we would say, and being open to learning and not thinking that you're going to have it all figured out. For example, and I've shared this with Doug. When I took on this position here and began building relationships with different indigenous communities around the country, it became very clear to me that there isn't just one native way, that it varies. There are subtle differences in the tribes around the country. And so I could spend the rest of my days, even if Doug had that switch installed, to flick off the left side of my brain, I would still never even scratch the surface on truly understanding Native culture in that way. So, but it also, cultural competency also requires this process of ongoing, taking a look at yourself and staying open, as I said, to learning and growing. Sometimes when I've done trainings in the past, I learn more from the participants than they learn from me. And it's funny how that works sometimes. And lastly, it really again looks at the power imbalances and trying to develop that sort of flattened relationship where both parties are benefiting, and there's sort of a kind of a symbiotic relationship. So it's both people are benefiting in some way from learning about one another when it comes to cultural competency. So, and I referenced this earlier, Doug, other cultural considerations, if we think about, the over 500 federally recognized tribes in the lower 48 and the over 200 tribal communities in Alaska, there are a lot of components to, from a cultural standpoint, a lot of nuances, a lot of differences amongst these different tribal entities, these tribal nations. So really, if you overlay that with the cultural considerations, and then we tie that to our own work that we're doing, especially if those of you that are working in a tribal community or on reservation or working in a tribal agency, it can be, it can be very, very complex in many ways. Questions or thoughts as we're moving forward? Doug, anything to add to that, or anything that jumps out at you, or anyone else that's listening?
Again, with the non-judgment, right and wrong, those come out when with that linear thinking, everything's left to right in the square.
Yep.
And here there's no right way or wrong way. And everybody may have something similar. So the main thing though is with this trust building is we're kind of like a mirror image, of what we put out there is what we'll get back, and so it's better to have a smile on and for us here, we refer to the clients as relatives because that's what they are. Have a smile with meeting with relatives and letting them know that it's okay and nobody's perfect.
Thank you. Yeah. I see a chat from Louise. She said a little bit earlier, also a broker role between cultures, professions, and institutions. I like that. I don't know if you want to clarify that a little bit, Louise, or if you're able to unmute.
Yeah, okay, I did it.
There she is. Yes. You do have a voice. Yes.
Yes, thank you. Language is part of it, but also there may be some level of technical interventions on maybe on the medical side where that doesn't translate well to a client or patient, and there's not good communication. So I've gone on appointments with patients in order to either interpret for them or to advocate for them or to see that maybe they don't know how to speak up, and to see that the point gets made of whatever the need is, and get the proper follow-up between the institutions. And God knows that there's such a maze sometimes to get benefits and advocacy and whatever it is you need, even if it's a very positive thing like a scholarship or something, you might need so much paperwork. And so to be that it's like family, to be that big brother or sister, to take the person's back and help them out with something, and that maybe also brokering that they may not have trust for an institution, but if they could trust me, then I would be able to negotiate the system with them and for them. And it's so many different ways for it to get done, and that even any of us, you know, I need a broker to get me through some kind of social service mazes or whatever else, paperwork, or get my taxes done.
Yes.
So there's a lot of mentoring and hand up and everything that we need. And as far as being family, you know, I thought of one thing that I did a lot of work in my career with people who were homeless. And so I thought of when Mr. Widow said family, somebody said, what do you know about being homeless? And it just turns out that my father was a homeless child. Hmm. So I said, yes, I know, it's in my family too. Hmm. Yeah. And so this way, maybe that's another way of brokering, is that to try to break down those barriers between yourself and the people you're trying to serve, and the people, the systems that you're trying to work with. Because sometimes it's part of the fear or the fear of change that people will find fault, and there has to be some way to break down those barriers between the person you're trying to help and the help you're trying to give them.
Yeah, those are great points, and I do appreciate you unmuting, and it's good to hear from you. So thank you.
All right, thank you.
Thank you. Mm-hmm. So let's talk a little bit about trust building for a few slides here. This we know is essential, and I think most of you would agree that trust is mutual. It is sometimes very difficult to build and maintain, and certainly easy to lose. So that goes, you know, for probably most settings. But professionally, you know, Doug mentioned this first bullet point about non-judgmental, no right or wrong. You know, no matter how hard you try, your own values and your own biases are going to seep their way into most of your therapeutic relationships. But setting them aside and being aware of them can be a really good step toward really connecting with and hearing your patient or your relative as they engage with you. And this idea of unconditional positive regard, you know, that I think is another term that I would use. Even if I have a relative or a patient or a client that I'm working with that is living a lifestyle that I just don't understand or don't agree with, I need to, as a professional, I need to show unconditional positive regard. Strengths-based, I think this is really important, especially for patient populations that have struggled to move forward and to have positive outcomes. Finding the good, finding the strengths, finding what that patient is good at or was good at. One of the things I used to ask my patients initially was, tell me about a time when your life was really going well. And this would often, they would often light up and say, oh, yes, it was, it was 10 years ago and I had this and this happening and I was working and, I still had contact with my son and then that would give us a starting point. And I remember I had a patient that he had to go all the way back to when he was 10 years old before he could recall a time when he remembered things were good. And that told me a lot too about what he'd been through and what his life had been like up to the time before, up to when we started working together. Authenticity, I think, is often undervalued. This can really be a really important keystone in connecting with patients and building that trust. If I'm going to give them some honest feedback or share with them something about my own experience, it needs to be authentic and genuine. And if not, I really am risking coming off as being aloof or misleading. So that's important too. But it's very, very important, I think, particularly with American Indian Alaska Native patients. But I think this also, applies to non-Native patients as well. Introductions are important. Doug, any thoughts about that? What are your thoughts about introductions being important, specifically with the relatives you're working with?
Introductions, that's kind of through the process of what we do here is we would have them do a family tree, and what we would do is we would have them find out where they come from, so they have a good idea of where they're going. Throughout the process, like we have a lot of them that finished the program but are still coming back, still learning the language, and actually introducing themselves in the language, and during their prayer and in the language.
Yeah, thank you for that. And the last couple of bullet points, there are some examples, but I think in just not making assumptions is a good thing to consider when establishing and maintaining trust. Don't assume things about your patients based on even what their chart says. It's important for you to explore this and not fill in the blanks. That can really damage the potential trust being established. A couple of other things to consider, engagement is a big one. Several bullet points on engagement, in a variety of different contexts. I know Doug and I are working on a presentation, a workshop on engaging patients in substance use disorder treatment, especially in early recovery, and how important that is. Sometimes you have just one shot, at making that impression on that patient, especially if it's a patient's first treatment experience. This is really an opportunity for them to understand what it means to be accepted, and listen to and to have a positive experience. I used to have clinicians say to me, Steve, you know, this, I'm just not getting anywhere with this patient. They're not making any progress, or I don't feel like they're really ready, you know, for making these changes. And one of the things that I would remind them is that they may not be. But your role as a clinician can be to make their experience something meaningful and something positive and something that perhaps when they are ready and they come back for that second admission, that they're going to remember again how they felt and what their experience was like that first time, that it was something good. So engagement comes in a lot of different forms. These are just some things related to to nutrition, where you meet with the patient. You know, I would sometimes, if I met with somebody as a walk-in, they were in crisis, one of the first things I would ask them was, had they eaten that day? And, you know, if they said, I haven't had anything to eat, you know, for 2 days, I would say, how about we make you a sandwich and get some Gatorade in you? You know, that can be a wonderful way to engage. We may not talk about evaluation or getting into detox, but I can get them something to eat. That might really be a way to engage them and know that I don't have some agenda, you know. But just simply how your office is set up or how a group room is set up can also impact how trusting and how well the patient or the relative may engage with you. Also, you know, and you know, Doug, you can comment on a few of these things, but affirming their own American Indian or Alaska Native heritage, you know, asking questions about their tribal nation or their community or their family. This can be a really important means of engaging and connecting with them and beginning to establish some trust. You know, Doug talked about them presenting a family tree, you know, to find out, to help them explore and share with you who they are so that they know where they're going. That's a great example of that. Being able to access cultural knowledge and spiritual practices. And then, you know, we know incentives can be a big part of this trust building as well. And talking with them about those incentives, you know, what can I do to help you move forward? What's going to help you move forward? Is the patient externally or internally motivated? You know, that can be important and help you adjust your approach in engaging them and building trust. I had a patient show up to my office once and they were very upset and they said, Steve, I relapsed over the weekend. You know, I caught it in time. I realized it was a mistake. I feel bad about this. And please don't tell my PO. Please, just don't tell my PO. And I said, Jim, I'm not going to tell your PO. You are. and I said, you're going to call them. And I'm going to be with you, and we'll talk with your PO together about what happened and how we're going to handle it. And that I said, that's going to mean a lot to your PO because he's used to being, you know, lied to and misled, and you're going to call him and give him some truth and own it. And it really played out well. It changed things because we called his PO, and his PO was appreciative that he let him know, and we made a plan to move forward and prevent that from happening again. So these kind of things, you know, if they know you're kind of going to have their back, like Louise said, that can really be a trust building opportunity. So again, looking at strength-based approach, authenticity, looking at some positive steps already made. I used to ask patients if they'd had periods in the past where they were able to remain abstinent and experience recovery, and we would focus on what was working then and apply it to now. And really having that sense of advocacy that I'm going to collaborate with you, and I'm going to highlight, your strengths, and respectfully address, areas that you feel like you want to explore and improve on.
I'd like to add that putting them first, that's what we call our program.
Yeah.
And the language is Toaya Tokaya, and always remembering that, and instead of putting the documents first, come around your desk, greet them, and also they know when they're coming to you. They know when you're putting the paperwork before them. They're considering that more important than they are. They know all those things as you come in. So just be mindful of them, and you start gaining that trust.
Yeah, that's good. Appreciate that, Doug. Just some other things to keep in mind, asking yourself, sort of looking at the system with which you find yourself working in, whose needs are being, addressed here. And these are just some examples of ways that you can look at and sort of cross-check that. For example, does your intake forms, does your screening mechanisms, are they inclusive? Are they updated? Are they considerate of all peoples? These are just some examples of asking yourself within the system that you work, whose needs are being met. Again, another slide on trust. Looking at other barriers that may block that. Looking at biases. We've talked about biases a little bit. Looking at referral sources. Can I make a responsible, timely, and ethical referral to someone else in the community, that I can say to the patient, this person I'm referring to you is good, and let's give them a call and let them know that you're interested in working with them on that specific issue that we've been talking about. Lack of funding. One of the reasons I stayed at the agency that I worked at so long is because we served anyone. It didn't matter if they could pay for their services or not. They would receive services. And, that broke down a lot of barriers, and let people know that we were there for them, not for the money or what we could take from them. And then just, unrealistic timeframes, expectations, those kind of things. Those can also be impede that building of trust and engaging with the relative in a clinical setting. Confidentiality. I mentioned this earlier on. This is in the substance use disorder field. We know that confidentiality is sort of the golden chalice. I mean, it is what really makes the work we do possible, because when a patient engages with us, anything we talk about is protected, and there are issues within Native communities and non-Native communities that remain very stigmatized. So confidentiality is absolutely key. Now I have talked with other Native colleagues, and Doug, maybe you would be willing to comment on this. That last bullet point, there are situations where in smaller Native communities that confidentiality may be really difficult to maintain in certain situations. That can impede trust and openness. Doug, I don't know if that's something you want to comment on or have experienced that, yourself.
All depends on how how you take a look at it. An example would be, for me, what first thing that comes to my mind is that you have people that let's say they're, they say we have a suicide protocol here, or and you call the police, whatever, but somebody will get hold of somebody, and they will let somebody know to go check on this person after hours. And so usually stuff like this happens all the time. And the other thing that comes to my mind is an example would be what we create here is we create that support, and that and they're having other relatives become healthy relatives, healthy family, and so they become their support. So if they're missing an uncle, a grandma, or whatever, then they would find somebody that is healthy to fill in that spot. And so that's what comes to my mind.
Thank you. Appreciate that. I think most of you are fairly familiar with what constitutes a breach of confidentiality and how that can be breached. There are a variety of ways that can be done. I don't think we need to talk about that too much unless somebody has questions about that. We will. Oh, yes, I see Louise has her hand raised.
One thing popped in my head when a program was serving people who were positive. In order to protect their confidentiality on the car fare sheet, they had them sign a sticker. And so then the sticker was put on the car fare sheet and they wouldn't see other people's names. So I thought that was a very clever way of protecting the confidentiality.
Yeah, I like that. With electronic health records becoming more the norm than the exception, as we move away from paper to, there are a lot of elements that make it less likely for there to be an accidental breach of confidential information. But this next slide, this just shows sort of how this element of trust can interface with the different areas of that relative's, experience within the care that they're receiving. So that's just sort of a visual there, when we see, trust being central to some of these other components or considerations in the quality of care that relative or patient is receiving. Again, this is something to just keep in mind. Is the biggest mistake we can make is assuming that someone else sees things the same way that I do, and that can get you in a lot of trouble, both in your professional life as well as in your personal life. So that applies to a couple of different living situations. So, but it's just really important. Again, the key here for me is assuming. Anytime I assume, I'm creating expectations and projecting those onto someone else, and it can really set me up for misunderstanding or a lot of other difficulties in communicating and working with someone, whether it's a peer, or a colleague, or friend, family, or of course, relative or patient. So again, we're going to just kind of move through these. I want to make sure we stay on time and have a couple minutes for questions. These are just some steps to engaging Native patients. And as I said, Doug and I don't know if he had to step off. Maybe he might have had to step off. Maybe he'll come back. But I know Doug and I are working on a workshop on this very topic. But those are just some steps that are suggested as a way to engage Native patients in the treatment experience, and they all have their place in this process. And I never understood when I first started here the idea of circular migration, where I might have a patient that I say, well, group is 12 weeks long, it's once a week, and they might say, well, I have, I'm going to be gone out of state working, the last month and a half of my groups here, or they might say, I'm going to be in ceremony for the next week and a half traveling, and I'm going to be out. So understanding these kinds of things are really going to help engage and maintain your therapeutic relationship with your Native patient or relative as you work with them in a treatment setting. And I wish Doug was still on so he could jump in and add to that, because I know we've been talking a lot about this outside of this meeting. So again, looking at some examples or some additional information about each step. These are important, and things to keep in mind as we move through and look at engaging with our American Indian Alaskan Native patients in a clinical setting. So I just want you to keep in mind, I think that second bullet point about family too was for myself, having this sort of nuclear Western view of what a family is. It became real apparent to me that the concept of family is very different in many Native communities, much more expansive and interrelated. And I don't know if anyone has something to add to that that's with us now, but it's something to keep in mind as we look at these different steps. Again, understanding, Native-centric worldviews, and understanding that there are things to consider regarding medical models, the stigma connected to health concerns, and the importance of modesty and nonverbal communication. Understanding the roles of Western medicine. Again, for many Native people, Western medicine has ties to historic and traumatic experiences. Medical models can also be tied to other non-Native experiences. And, and we know, and I've learned about the damage of misdiagnosis, the dismissal of traditional healing practices and medicines, and even, in a more stark example would be the sterilization practices that occurred in the first half of the 20th century in the name of medicine and in the name of Western medical practice. So those are some things to keep in mind when we're looking at engaging with our Native patients in a clinical setting. I sure wish Doug was still here so he could add to some of this, but providing formal introductions, again, this is important to, and I think it's important as well in non-Native settings, but providing formal introductions and taking that time to establish the connection before you just jump right into business. We would call this, small talk or sort of non-clinical discussions prior to, having more directed or clinical discussions or interactions. So there's an important balance that you strike between, being professional and also being personable and approachable. And it can take some practice for some, and for others it comes very naturally. Again, providing formal introductions, shaking hands may be necessary. I know if Doug was still on, one of the things he shared with me about some of the Great Plains tribes were the difference between a left-handed shake and a right-handed shake. And I wish he was still on to talk about that, but the way he explained it to me was a left-handed shake meant I expect nothing in return, and a right-handed shake was more, this is sort of a transactional, agreement between us. But I thought that was an interesting concept, and I've kept it in mind as I've been shaking hands with people in different settings. Small talk is also a great way to gather information about the patient, and I think this holds true for non-native patients. But it can be a great way to break the ice and build that trust and engage. Explaining confidentiality again. This can be a very delicate matter for native patients and non-native patients alike. But just having an awareness and about the Western medical practices or some of those experiences that a native patient may bring to your office, where there was mistrust or misleading or manipulation, and so they may be reluctant to know that it's okay and that their experience with you is private and protected. So again, it goes back to that relationship and making that connection and establishing that rapport and building that trust. And again, just to build on that, helping understand that things are protected, whether it be a file cabinet or probably more likely now, a secured server or something of that nature, or secured laptop or something electronically that's secured. And who has access to charts, and these can be great orientation pieces too, and explaining reasons why you would forfeit your rights to confidentiality when a breach of confidentiality can be warranted without consent. Those are important aspects to make sure that your patient understands. And again, we're taking this back through a cultural lens, but then we're also taking it all the way back to the beginning and talking about your readiness as a professional and how that interfaces with the agency that you work with and the colleagues and peers that you also look to for support regarding the work that you do, your supervisor or your clinical director. Again, I mentioned this earlier, but understanding circular migration and understanding that there may be accommodations that need to be made when it comes to engagement, frequency, and duration of the patient's engagement in services. Again, it can be a challenge to the sort of integrity or the flow of a patient's treatment, but again, I think there are reasonable accommodations that can be made if a patient needs to step out and then return to the group or to your individual work. But to make sure that you're not seeing that as signs of resistance, or I can't reach them, or they're not ready to do treatment. It's important to keep that in mind. So that's why we included that in those engagement steps. As we near the end of the slide deck, I want to just make sure we touch on supervision. And this relationship you have with your supervisor, as many of you know, is vital. And Luis, I see you've got your hand up there. I'm sorry I missed you.
This is a very wonderful presentation today, and it's got me thinking about so many things. But if there's this circular migration, then what came to me is anticipatory guidance for building that into the treatment so that you take the treatment with you. You're not against it. You're going to say, well, how are you prepared for it? Because we used to do that around holidays. The
Yes.
holidays are coming. This is what you do. The meetings have 24-hour meetings. And so that it's not like on and off. It's not binary. It's continuous. So I'm going with you. The treatment is going with you. We're going with you, and let's prepare for that.
Yeah, and I think with technology now today too, there might even be means where you would be able to, to have a telehealth check-in session or a phone call much more readily than you could years ago. So I think there are a lot of strategies that can be used to keep the patient engaged and not assume that they're just being resistant or unmotivated. That's where you're assuming, and you really can damage the trust and that therapeutic alliance that you're building with that patient, because it's mutual. It's just as important as it is for that patient, for that patient to trust you. You must also trust the patient and learn to understand and respect and have insight into their world and the lens that they see the world through. And that goes back to cultural competency. It goes back to your readiness as a profession, as a professional, and how that interfaces with your own values and the agency that you're working with. And those are all things to consider. So it's multifaceted in many ways. So again, the supervisory relationship is absolutely essential. There are times where it may not be productive or supportive. I've had supervisors in the past that, I really struggled to connect with. But for every one of those, I've had, 5 that I've really connected with, and a couple that I still stay in touch with to this day. But it's your obligation, your ethical and professional obligation, to seek out that supervision and not just work under this sort of, take a look at my files when you get a chance kind of, approach. Consultation with your supervisor is a component of decision making. And again, it's your ethical obligation to seek out that clinical supervision to help guide you. And even if you're a seasoned clinician, it's good to have another set of eyes on things and another perspective. So really important. 3 goals of effective supervision. Well, these are pretty self-explanatory. Really want to look at, creating this idea that, as a supervisor, I took on this sort of servant model role of supervision and leadership, where I would say, hey, I'm working for you. What can I do to make your work more meaningful and more manageable? And that was essential, because I knew as a clinician, I was fortunate to have, one of my first supervisors have that same sort of approach, and it made all the difference in the world. Not only did I learn and grow, but I felt, safe and supported throughout the process. Again, effective supervisors, these are just some bullet points to keep in mind. I love to lead by example as a supervisor or a clinical director. Being able to jump in and do direct services once in a while and try not to mess things up too much with the paperwork. You can get a little rusty with that sometimes, but being able to facilitate groups and let others mentor and observe some of your own skills. These are wonderful components to this list of bullet points here. So we don't have to go through all these, but I just wanted you to be aware of these, and I'm sure that some of you can relate to a few of these as a supervisor or being supervised. The last couple of slides, I don't want to rush through these, but I want to make sure that I'm honoring everyone's time. We've got about 15 minutes left, and I want to spend the last portion of our discussion today addressing something that I think is extremely, extremely important, and it really relates to help for the helpers, tending to your own spirit, taking care of yourself so that you may then better serve others. And it took me a long time to realize how important this is as a direct service provider. I remember reading somewhere that Mother Teresa would take her group of nuns and require them to take a full year off every 5 years so that they could replenish and recuperate and then return and continue their work. And I thought that was amazing, almost like a little sabbatical. What a world that would be if we could incorporate that into the work that we do and taking care of each other. But stress can really have a number of effects on a person, and it can really pull you down in a number of different ways. And if we look at this from that sort of biopsychosocial perspective, that umbrella, and we know that stress has an impact on a number of these things. Some people handle stress better than others. It manifests different ways from person to person. And I added, another component, and that's the spiritual component. And don't confuse this with religion. Not that there's anything wrong with having, religion as your vehicle to address your spiritual needs, but understand that the spiritual component to this can also be impacted. And that's why I often refer to it as tending to your spirit when it comes to self-care and being mindful of that. It's easy to talk about. It looks good on paper, but from personal experience, it can be real easy to be so concerned about helping others that you don't take care of yourself. So again, we're going to tie this back to professional readiness. We're going to tie this back to our obligations that we've made to our patients, to our coworkers, and even the obligations we've made to our own family and friends, because this can impact those relationships as well. There are some basic stress symptoms. We know these. We've probably experienced some of these over time. I added relapse in there for those of us in recovery and working in this field. That can be a serious concern. So it's important to understand that stress can manifest in many different ways. I also want to make a distinction right off the bat between burnout and compassion fatigue. Burnout is really being overwhelmed and tired and exhausted from the process. The paperwork, the meetings, the managing of patients and working with colleagues, and just the getting your things in on time. Those kind of procedural things are usually associated with burnout. Now, there's overlap between burnout and compassion fatigue, right? Compassion fatigue, in my definition of that, and if somebody has a better one, send it to me. But my idea of compassion fatigue is really the cumulative effect of experiencing others' trauma, grief, and loss and struggles vicariously. And that over time, if not addressed, can really impact the ability for you to do the work that you do. So I want to make that distinction because I think I often confused the two. They definitely work in conjunction with one another oftentimes, but they're two different things. It can be related to the work environment, those you work with, or if you're working with patients who have chronic disorders or acute or long-term cumulative co-occurring disorders, that can really create a lot of that compassion fatigue. One of the things I experienced, and I'm sharing this with you guys, I don't share this very often, but one of the things I experienced was, and I'm still working to recover from this, is my ability to experience empathy for those in my family or outside of my work. It's very unsettling to not feel that when I knew I should be. And I don't know if anyone else has experienced anything like that, but it was very unsettling, and frankly, it scared me a little bit that I couldn't feel that anymore. And that was that was a clear sign to me that I'd not been taking care of myself. So really important to keep those things in mind as you do the work that you do. Who benefits the most? Who benefits the most? Be thinking about that. We're going to touch on that in a minute here in another slide, but who benefits the most from you taking care of yourself? That's the question I want to put out there rhetorically for you guys to consider. We're going to come back to it here in a second. Here are some stages to burnout. These are a set of stages. There are some other variations of this, but this is pretty straightforward, so we don't need to necessarily go through that word for word. Looks like we're missing a bullet point there. Maybe I was going to add something and I forgot. I don't know. We're missing a bullet point, so we have to track that down. But it can be really, burnout can really impact the quality of the work that you're doing, and it can even the quantity of work. So this idea of help for the helpers, and here's that comment. The greatest gift, and I use that term fairly loosely, but the greatest gift you can afford your patients, your colleagues, your own family is the practice of self-care and tending to your spirit. I used to say to my clinicians, you need to have some time off, and we're going to make that happen. And we're going to make sure you take that time off, and we're going to cover you while you're gone. Your patients will be in good hands, but I want you to go take care of yourself. And when you come back, your patients are going to get the best of you. They are going to get the very best of you, and not a diminished version of you. And again, that sounds good, doesn't it? Looks good on paper, but it's tough to pull off, especially if you're in an agency that isn't supportive of that or is indifferent about that. But we often work with relatives or patients that bring a lot of issues to the table. And if I'm going to be telling my patients and colleagues to take care of themselves, then I need to do the same and practice what I preach and follow my own instructions. Yes, work stays at work, leave it there. I was pretty good at that most of the time. And then also consider accessing support services in the community or through your EAP. This is often done, it's done confidentiality and often at little or no cost, depending on the agency that you're with. And then, of course, we've got some stress management, suggestions. Humor is a big one. I think without humor, I might have just burst into flames at some point during my work in a clinical setting. So I know that humor is integral. One of the things I love about Native culture and communities is their use of humor. I was told once your Native colleagues and friends start making fun of you, then that means you're in. So I always love that. And I'm pretty good at dishing it out. I can't take it very well sometimes. So I'm still working on that. But here are just some ideas, you guys, for stress management. And, I can't tell you how to take care of yourselves. That's something you really need to tailor to your own style and needs and situation. But there are wonderful ways to do that. I tend to go to a couple of AA meetings a week. I sponsor others and have a sponsor, and that's sort of the pathway that I choose. And then engaging in other activities that I enjoy. I boxed for 7 years. What a great way to get a cardio. I'm not a violent person, but it sure felt good to punch that bag or my boxing partner. If we had the right pads on, we couldn't hurt each other too badly. So, but making exercise fun, doing something to get your heart rate up, these are known to have direct impact on reduction of cortisol and stress levels and blood pressure and things like that. So, oh, you guys, we could keep going. I know we're real close to the bottom of the hour. We've got a few minutes left. Just wanted to open the floor. It's just great to see you. I really appreciate you guys staying on with us here for the last 90 minutes. And it's good to see some familiar faces too. I want to open the floor up though. Any questions, anything you'd like me to circle back to? Or, yeah, Alexandria, I understand. And yeah, that can be a big barrier to your own professional growth. And yeah, if you ever want to reach out, you email me. We could talk more about that, or maybe I have some ideas that could be helpful. Yeah, that's great. Great point, Greg. Big barrier we know is you can have all the virtual services in the world, but if you're somewhere where you can't get a reliable signal, you're cut off, and you really don't have access to that. And that goes for telehealth as well. Yeah, I appreciate it, Willamette. Always good to have you on. I appreciate your continued support and patronage. I really do. So yeah, we're at the bottom of the hour. I don't know if anyone else has anything else they'd like to share or comments. I'd love to take any comments if you want to unmute and talk about anything. Thank you, Jeff. Thanks for coming on. I appreciate you. And I think, yeah, Doug texted me and said he had to see a patient, so he had to step off. But really appreciate you guys. And next month, we are going to talk about, oh, that's okay, Serena. I know we are all going in 10 different directions, so I get it. And we have recorded this event, so it's something that if you wanted to go back and catch an earlier portion, remember too, we're going to make these slides available in a PDF. I always say if you use these slides, use them for good and give credit where credit is due. But always like to share this kind of information with everyone. I did post a link to a short survey. It's very short. Anything you answer on there is private and confidential. I can't link to you in any way. If you don't have time to do that today, we'll reach out to you post-event with an opportunity to request CEUs. We're going to offer 1.5 CEUs for this broadcast today, and a copy of the slides, and then a link to the recorded webinar. So let's see if I can take these slides down. There we go. Now I can really see all you guys well. So that concludes today's broadcast. Again, thank you. I'll have Dr. Matt Ignacio talking next month on HIV, STIs, and substance use disorders. Look forward to having him as a guest lecturer. So come back. First Wednesday of every month, we'll be here. Until then, I just want to say to all of you, thank you. Stay safe, stay healthy, and most importantly, stay connected. Okay? Take care, everybody.
Thank you.
Okay. Dogsha.